let's begin. So today isn't exactly a breakdown of everything. I just wanted to do this quick session because many of you are already enrolled in the long course and the short course, and you had some questions about what's going on. So before I dive into what we have here today for the rest of you, I'm just going to go into an overview of what you already have access to and how to utilize that. Okay. Firstly, all of you who have enrolled in the long course, let's talk to you. Um, you all have access to the drive, right? The drive has many folders. Please go through it meticulously. You will see, and I think the short course people also have access to the exact same drive. Go through it meticulously. You will see some notes, some PDF notes that I've made. Those are just OSCE structures that you need to follow. Now, they're not hard and fast, and we'll have a discussion about this as well. OSCE is not about rote learning scripts. It's about your natural interaction, but that just gives you a basic framework of what each station should have. That's it. Second, you will find some cheat sheets there, especially the history ones. I took a lot of time to develop those cheat sheets. The reason was I personally struggled with history stations. And I would always struggle with finishing those history stations within the 8 minutes. That was my problem. And I noticed over the years, with candidates as well, that they would struggle with finishing up those stations. And the reason was not having a clear set of questions to ask. Now, if you're not enrolled in the course and you're looking for something free that helps you with these kind of things, check Geeky Medics out. They do have some stations, and that can give you a little bit of an idea about how to take a history. It's not emergency related, it's not MRCEM related, it's mostly lab stuff, but you understand what they're trying to do. For those who are already enrolled, you have the cheat sheets. Just go through those questions and you kind of rule out 5 important differentials, you rule out the major stuff, and you get to the diagnosis because you ask targeted questions. So those are good to utilize. Go through them before the course so that you are able to practice effectively with me and with other people eventually when your exam comes around. Second, you will see some research guidelines there that are available everywhere else. So those are not something interesting, but there's another sheet in the research section that you will see has details, like landscape details, and I'll see if I can show you towards the end of the session. Those are good for research stations. They have step-by-step guidelines, and that is also available for free everywhere. So if you want to have a look, just Research UK, find the guidelines there. Those are just the detailed guidelines, not the algorithms. I've updated sepsis guidelines in the research topic, so do have a look at the sepsis guidelines. I have put the flow charts there because they've recently updated the sepsis guidelines. They've changed the amount of fluid you give. They've changed some other stuff. I will make a video on that one in the coming few days just to give you an update on like the sepsis stuff they've updated recently. What else is in the site? You also have access to the long videos. The long videos are really true to their name, really long. And that is our last year's long course. So I've given you access. The reason was I want you to listen to those videos, make your own notes, and be a bit more aware when you walk into the course. And that way, when I ask you questions or when we practice, it's more interactive than you just learning and writing down, because OSCE is not about learning and writing down. But you do have to do that at some point. And I noticed in my last live course that many of you were so focused on writing down and making notes that you were not able to focus on the live discussion that we were having, and it wasn't as interactive as I hoped it would be. So that's why I decided to give you access to the long videos now. So you have months to prepare, go through the videos, and then when we do the live classes, you are more interactive and have a discussion with me, and we're able to figure out how to best have an introduction sorted or have station flow going. Okay, I hope that helps. So that's about the drive. Now let's talk about the long and the short courses. And this is just for those who are already enrolled because they had questions, okay? The rest of you will have a discussion about, we have a PPT ready, don't worry. The May course people, all of you who have the May exam date, listen up. Your course is going to start from the 5th of May to the 11th of May. Those are live sessions, and those are strictly practice sessions. Like we will have back-to-back stations. You will be going through the drill, feeling the exam pressure, and going through each and every station commonly asked with me, supervised, and I'll give you feedback. Now, the May courses or the short courses, I don't take more than 6 or 7 people. The reason is I have to give individual attention to everybody, and I don't take a large group. So we are already at half capacity for that course anyway. If you are interested still and you have a May date, just contact us and I will let you know if we still have a spot remaining. But ideally, I do not like having more than 5 or 6 people because it gets difficult to manage each and every one of you. Secondly, we have mocks as an option if you are just interested in doing a mock exam. For mocks, you have to contact us separately. Just leave me a message or an email, however, and we'll have to set up a date according to your exam date. And we can sort that out. Mock exams are 3 hours, 10 stations, back to back, and then we have a feedback. So that's about the May course. Let's talk about the long course now. The long course, people, you will have to wait a bit longer because we start in July. But you have a lot to cover in the meantime. So please try and watch at least 1 or 2 videos. There are a lot of videos. They're really long. It's very difficult to stay focused. So try and watch all of them before you join us for the live course. In the live course, we will again be going through the stations, but it's not as rapid, I would say. We take it really slowly. We take it week by week. And so we build your concepts. We help you find your own style of doing the station, and then you practice with us. And we also have different groups that will be helping you practice. So mentors that have already given MRCEM will be practicing stations with you and giving you feedbacks along the way. Okay. So 6 weeks for you. Every week we do different type of station. We learn as we go. I would be practically giving the demonstration, and then I would be listening in while you practice with the other mentor. And then I give feedback. That's how it is. So the practical demonstration is me, and then I have mentors who will simulate, like as a patient. You do the station with them. I'm listening. I'll give a feedback. That's how the station is going to go. Okay, so that is about the 6 week course. Also, if you have enrolled in our long course, obviously you don't have an exam seat. So I understand the hesitancy and a lot of stuff. With the long course, we are already at capacity, by the way. We just had 20 seats and they're all gone. So I'm not looking for new people at the moment. Yes, it's going to be case-based because we do it once a year. I get like some people who might go for like a refund, or they get a seat in the coming date and they just switch to another course, and we might have a few slots open up. But so far, we are at capacity. And I'll let you know if more seats open up. That's why we're not marketing the long course anymore. Now, with the long course, because you don't have a seat yet, if you get the seat by the end of this year, like November, you don't need to take another course. You're sorted. You just need mocks if you are interested. Otherwise, you will have access to the course recordings, the materials till November anyway. Okay, October, November, I guess. If you get a seat in the next year or the next coming year or year after that, and you're like, I don't know what to do. I've already done the course, but I don't have access to the materials anymore. You have 2 options. You can either take the recorded version of whatever course you attended. So the long course 2026, you will have the recorded version of it. You can take a monthly subscription for that month when you think you will get the seat. If you get the seat and now you're worried, just enroll in our short course. Anybody who has taken a long course gets 50% off on the short courses. So you already have that advantage. Just leave us an email, remind us that I have taken it. We would have a record and we will sort you out. Don't worry. Okay, that was another common question that everybody was asking. Like, what do I do when I get the seat? So don't worry. Secondly, if any of you enrolls in a course and has taken the offline subscription, please unsubscribe to the offline subscription because it's the same videos that you will get access to in the course. So don't pay extra. Okay. That's another thing. We had a common problem coming up. I hope that is all the questions that all of you have. If you still have questions when it comes to the course, and this is only for the enrolled people, just comment in the chat box before we begin with the PPT for today. Any questions? Any concerns? Happy so far? Okay, brilliant. Right, now let's talk to the people who are new to OSCE, want to understand how we're doing, what does that mean, how can I start preparation, what do I do? Number one, join our open OSCE group. There's a drive there, I share videos there, I share information there that can help you. Go to our YouTube channel, you will find lots of free videos there. And I'm in the process of uploading more short OSCE station videos just to help you out. So I hope that helps. Now let's talk about the OSCE basics. So this is the exam overview. You have 16 stations, 8 minutes each, with 2 rest stations. You will have a task in every station. Please look at the pie chart whenever you go for the exam. The pie chart will tell you which domain are they testing in this particular station. Now, anybody who has given the MRCEM exam before will tell you this. After the result comes out and you look at the result chart, you cannot tell which station is marked for which SLO. And the reason is the pie chart. According to the pie chart, they will decide if they were going to consider this a history station, with history having like 50% of the station, and then the rest is communication and stuff. So that's how they do it. But it's still a bit difficult. Oh, it's not 2-minute reading time, it's 1-minute reading time. I'll correct that. It's 1-minute reading time outside the station, and it goes by really, really fast. Second, domain-wise, all 16 stations will have communication and safety netting. Okay, all of them. At MRCEM level, it's safety netting and communication. You will see that at AFACEM level, we have communication and then leadership as well in all 16 stations. You will have that in some. Second, specialty learning outcomes. So let's talk about specialty learning. Let me just wait. Okay. So these are your specialty learning outcomes that you will be tested on: complex stable patient, resuscitation, applied knowledge, trauma, PEDS, procedures, complex situations, and then teaching and supervision. Okay, which is SLO 9, not 8. That's just number 8, but teaching supervision is SLO 9. And you will get 2 or 3 stations from roughly each. Now, what are we looking for when it says clinical assessment and management? Our focus is on history taking, diagnosis, treatment plan, safe prioritization. What examiners are looking for is a systemic approach, clear reasoning, and recognition of the red flags. Okay, that's how they're marking. Communication and interpersonal skills. So this is information delivery and empathy, shared decision making, clear, compassionate explanations. That's what they're looking for. Adapted to the listener. So you have to know who your target audience is and then be able to deliver that information. Then you've got professionalism and safety, which is ethical behavior, honesty, consent, respect. Here, what the examiners are looking for is integrity, respect, escalation when limits are reached. So this is mostly communication stuff. Procedure skills, what they're looking for is technical accuracy, aseptic techniques, communication during procedure. And what the examiners are specifically looking for is your safe preparation. Are you able to prepare all your stuff? verbalization of your safety checks, effective post-procedure care. Global rating. So this used to be separately marked before. Now it is included in your station in the 10 marks. You don't have a global rating score separately. So overall clinical impression and professional competence. And would this doctor be safe and reliable as an EM registrar? So that's overall they're looking in the station. Sorry. So again, weightage by station. If you see clinical management, you will see here clinical, communication, professionalism. And if you note, communication and professionalism is in all these stations. Okay, you can't get rid of it. Examiner expects you to have a structured approach. Doesn't matter what kind of station you get in the exam, you should have a structured approach. Okay. Empathy, composure, you need to have that for each station. Safety first, every single time. And then you should have a proper closure. This is roughly a little bit of a time management kind of scale. You don't have to follow it exactly as it is, but this is just to give you an idea. You do have a clock in the station. Okay. Excuse me. All right, sorry. So you do have a clock in the station, and it's an analog clock. You can take your own analog clock as well in the station. However, you will not be able to look at it. And also it's very difficult to like assess 8 minutes up or not because of how it is going. So whenever you're practicing the station, my advice would be to keep the timer to 7.5 minutes. Don't practice to 8 and see how you do. But always have the timer there. Do not start your practice without the timer and be like, I'm going to do the time later. No, do not try that. It's just bad advice. I did that when I was starting out, when I was starting my preparation. I would be like, okay, I'll do time later. And then it wasn't a good idea. And we struggled with finishing the station within the time frame. So bring the time problem in early so that you fix it earlier. Okay, so common time management pitfalls. Again, what to avoid: spending too long on introductions or open questions. Practice in front of the mirror. My advice would be to do the 1 minute thing. It helps. 1 minute introduction, good enough, and 1 minute closure. The rest, figure it out. Do not repeat information. Okay, just try and progress. If you've told something once, don't go around and saying it again. Try saying stuff in a shorter, concise sentence instead of a very long-winded sentence, okay? Always signpost between transitions, especially for history stations. You want to signpost, okay, now we're going to do this, now I'm going to ask you this, just a little bit, okay? If you are running out of time in a station, when you're going for the closure, always safety net. Mention safety net first, because that kind of saves you. Techniques for success, again, divide time mentally into halves. First 4 minutes for gathering information, and then last 4 minutes for explanation. That's what you can do. Signpost phrases like summarization. Now, I like summarizing. I really like this technique. The reason was I would summarize whenever I would be stuck. So you can use that. Whenever I feel like I'm thinking, and to avoid going into the station and saying like kind of stuff, which we tend to do, I would just summarize. So what you've told me so far, and I would just summarize everything, and that would help me mentally as well, figure out what's going on with the patient, and it would avoid these kind of sentences like so I want to ask, those kind of phrases. So if you do feel like these are the kind of phrases that you tend to rely on whenever you're doing the station, just practice. See if you can try and avoid these kind of jargons. You can avoid these gaps. You can avoid time lapses. I've seen people like glitch sometimes. They would just go silent in thinking, and that creates a very awkward gap in the station. So all these kind of things you want to avoid. Unnecessary and haphazard stations will score lower, even if you have the information, even if you're able to diagnose. If the consultations feel forced, robotic, or awkward, you're gonna score lower. Okay, so keep these things in mind. All right, so generic marks. These are the 3 areas where you're gonna get generic marks. Very important. Introduction, safety netting, and closure. And I don't care what station it is. Honestly, I don't care what station it is. This is where you score. Okay, and these marks are easier to have. For example, let's name a station. Communication, you still have to do all 3. Procedure, still have to do all 3. Teaching, still have to do all 3. Things can vary, the introduction can vary, the safety netting advice can vary, and the closure can vary, but you still keep it to these 3. And this is about 30% of your station. So 4 to 5 marks from just this. The rest you can collect later. So if you're not safety netting properly, you're in trouble. And safety netting is 2 ways. I always say that in 2 ways because we do it just one way and then we expect to get the full marks and we don't get the full marks. Safety netting is not just what to do when you get home. Okay, for example, they had a procedure and you're like, okay, yeah, you can now come back 4 days later. No, it's also red flags. When to come back to the hospital, right? That's the red flags. Sorry, is it still connected? What happened? Yeah, okay. So when to come back to the hospital, that's 1. Second, what to do when they get home. Third, if you're telling your like a colleague, an FY2, if you're teaching at that point, you want to tell them what are they looking for, okay, in the safety netting. It's not about the patient. It only, you have to tell them like, listen, if a chest pain is coming in, you're looking for MI, you're looking for these kind of red flags. So the safety netting for that FY2 is different, okay? So that's all it includes. And then there's a safety netting for management wise. So in a management plan, when you're trying to be safe, you have 2 types of management plan. It's the immediate management plan, something you're going to do in the hospital yourself. Never start your management plan with, I'm going to refer to cardio. That's not a management plan. That's you getting rid of the patient. So the first management plan wise, you're going to talk about what you will do. So I will attach him to the monitor. I will do blood pressure. I will do vitals. I will do this. I will do that, blah, blah, blah. And then you have a long-term management plan where you will be like, eventually you'll have to stay in the hospital, admission under cardiology, and they are going to do this, 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 this. Okay? So 2 levels of management plan as well. Introduction and closure, pretty similar and fairly easy, just some differences, which obviously you have seen the long course videos if you haven't so far. And for those who are not enrolled in the courses, just have a look at all the videos available. You will find some orientation OSCE videos just to have a look at. Towards the end of the orientation OSCE video, there's a sample station that we've done, just so you can have an understanding of what introduction closure looks like. But those are generic. Now, I would suggest have the same introduction and the same closure for all 16 stations. Do not experiment. The reason is you have different examiners and different patients in all 16 stations. So using the same phrases is okay. Nobody cares. And secondly, using the same phrase, you will get more confident. You know, you walk in, you have that knee-jerk reaction of saying, hi, hello, my name is Dr. Shariar. I'm one of the ED registrars. Can I just confirm your name and age, please? Okay, thank you very much. How can I help? You see, it just takes me like 10, 15 seconds to even go into the details of an introduction and then begin my station. And it's confident and smooth. Same goes for the closure. Have the same introduction and closure for all your stations. Same. Obviously, you will tailor it a little bit according to the type of station. For example, if there's a colleague, you will say, hi, my name is Pajwar. I'm one of the ED registrars. Can I just confirm your name and level? Okay, so that's how you just change around, but general just stays the same. Okay. Then what do we have next? Power of a strong introduction. So again, we've already discussed this, but if you have a strong introduction, it will really help. The first 30 seconds actually set the tone of the station, and the examiner and the patient decide if they want to pass you or fail you. So a good start, a good, strong, confident start. Be loud, not shouting loud, but be loud enough that they hear you. Don't be timid. Don't be looking down. Don't be like looking here and there and then introducing yourself. Be flustered. These kind of body language things do matter. So yes, this is important. Be neatly dressed. Have your hair tied back. Don't have them in a ruffled up open hair. It's not a good thing to do. So these kind of first impression things will help you gain those little marks. Safety netting, again, we had this discussion in detail, but protect your patient and your F2. Okay, so explain the red flags, have a clear follow-up, check understanding, do they understand, offer leaflets, document the advice, and then address any confusion, concerns they have. Many of the stations will have a conflict in the management plan. So always invite questions and see if they have a conflict and address it. And make sure you leave enough time in the station to address that conflict. Communication frameworks. So these are a few frameworks that you can use. We use spikes for bad news, SBAR for colleague handovers across specialties and referrals. And then we have the Calgary-Cambridge model for history taking. Okay, all of these we go into detail and discuss in detail in our long courses. I think this is also discussed in the orientation and another OSCE video that we have up on our YouTube channel. So you can have access to that. So Spikes framework, setting, perception, invitation, knowledge, emotions, and strategy. The best advice I can give you in practicing these is to do this on actual patients. Use this in your setting, even if you have a language barrier, I don't care. If you work in a setting where your basic language with the patients is not English, try and implement this in your language first. You will be surprised by how well the patients receive that information. And if you do this before your exam, like you don't have a date yet, you're still in the practicing phase, practice this in your language first, get used to it, make it a second hand, like a knee-jerk reaction for you, and then practice this in English and you will be surprised by how well you do in these stations. Second, SBAR handover. Again, try this in your clinical practice first in your own language. You don't have to do this in English first. Use it in your own language and then bring it into English and incorporate the English language and see how well you do. With Calgary-Cambridge consultations, again, this is for history stations, initiate and answering question stations. So initiating the session, gathering information, explaining and planning, building a relationship, so some empathy phrases here and there, and then closing the session. You have a self-assessment checklist. You can take a screenshot of this just for yourself. I think I have a self-assessment checklist up for everybody in the files as well. Like for those who are enrolled, you have a checklist for yourself, and you can use that for whenever you practice your sessions. And those who are not enrolled, just take a screenshot of this and use it. And if you're marking somebody, just score them according to this to see how well they're doing in the station. So this is your interpretation. So 80 to 100% exam standard, you're doing well. 60 to 79, you're borderline, you're missing a few things. And then less than 60% needs work. You need to work on yourself. Score every practice station so that you're able to improve something. And don't improve all things at once. Try and improve one thing at a time to see actual progress in your preparation. Okay, all right, so that is the end of this presentation. And from my side, if you have any questions, please ask away. I hope this was useful. All of you were just very worried about how to start, how to do this. If the questions haven't been answered yet, just ask away. so that we can still have a discussion about what you expected and what you want to hear. Okay. Doctor, from where we can prepare our structure for any station. I know, as you mentioned in your videos, that these days stations are hybrid. We do not get straightforward, but still, if you can explain. Well, there's so many options. You can use 125 OSCE book. There's an updated 225 version that has come in. Then I'm just going to type in St. Emlyn blog. This is a good framework to have. This is a free blog that you can visit and access to start studying. Now, the thing is, yes, there are hybrid stations, and nobody is going to give you a hybrid station breakdown, because the thing is, it gets too complicated. For example, I know in a history station, you will have a conflict as well. Any book you open, any vlog, any guideline you open is going to give you a guideline for history separate and conflict resolution separately. It is up to you to combine them together. They're not going to combine this because it's not going to make sense. But St. Emlyn's blog will tell you that there is a conflict in the history somewhere. Look for it. That's all they will tell you, but they're not going to tell you like how to tackle it. That comes from practical experience and actually practicing with mentors. The thing is, I have personally never taken an OSCE course, so I cannot tell you about other courses. I gave the exam. I found out the hard way that this is how you do the exam. I have an NHS experience. So I had a baseline of NHS. So I did not struggle that much with OSCE and I was able to pass it. Somebody who's an IMG might struggle a bit, which is why when we do the course, we have a discussion about where your baseline is and we start from there. We don't give generic advice to everybody because everybody's baseline is different. I can tell you from the feedback that I've gotten from some people, I don't want to take names of specific courses, but there's a very popular course that many people used to take, and I was tempted to take that one as well. It was too expensive for me back then. I didn't take it. They do like a 2-day thing in person and online, and then they also offer mocks. The problem was, many of you said, the ones who took the course, that it was too rushed. And it was so close to our exam, because when we go to London, it's too close to our exam. We were overwhelmed because they would tell us what's wrong in your station, but they wouldn't tell us how to fix it this close to the exam, and we would be stressed. That was the feedback. And so taking from that feedback, I decided to help the rest of the candidates out. And these were repeaters. And we had a discussion about how we can help them better. And so we decided to make sure that we would not put the courses that close to your exam. So if you need improvement, because you already have a seat, you've paid for the exam, you're already worried. We wanted to make sure that you're not that close to the exam and you're able to prepare in a safe, stress-free environment and able to improve before you go for the exam. That was the plan, which is why we have the long course and the short course. And even the short courses are at least 3 weeks or 2 weeks away from the exam, mainly because we don't want you stressed. So that is one thing that I noticed. Second, with regards to the hybrid stations, it is more of a everyday clinical scenario. If you think about your patients whenever they come in an emergency department, they don't just say, I'm history station. They don't say, I'm a teaching station. They don't say, I'm recess. You can be taking history and the station becomes recess, right? You can be managing recess and somebody wants to learn something from you. You could be looking at an ECG, teaching, and it becomes a recess problem, right? So this is the, I would say, presence of mind that you want to have in your exam. The exam is supposed to feel like an ST4 on the shop floor, actually looking at patients. That's how they've designed it, which is why it feels hybrid stations. It's not hybrid, it's just an actual real life scenario. That's it. So we call it hybrid because we were used to this system that, oh, this is history, just take history. Oh, this is teaching, just do teaching. And that was the old method. Now they want you to feel like an actual emergency physician and not just think of a patient as just history, just communication, just conflict. Okay, I hope that makes sense at some point. And you understand why we call it hybrid. It's not technically hybrid, it's just that this is an actual patient you're seeing, and I want you to go with that mindset. Okay, whose question was that? Let's just see who was asking that question. Dr. Vakas. Dr. Vakas, I hope that answers the question. If you still have concerns, please ask away. And the floor is open for all questions. Ask as many as you want. This will be the only webinar we are doing in 2026, by the way. So ask away. Oh, you're welcome. What could be the major reason if someone gets only 2 or 3 marks in a station? One, they made a blunder. They weren't safe. So patient safety is not going to be compromised on. If at any point you said something or you did something that would compromise patient safety, you are unsafe as a doctor. You missed something in a patient or you said something. Either way, they will fail you. They will not give you a second chance. They do not, as an ST3, ST4 level, they will not compromise on patient safety. So an unsafe doctor is going to fail. Okay. This can include you not looking at the expiry dates of medications. This can include you giving advice that is going to cause harm. This can include not giving safety netting advice when it could have saved somebody. Organ saving, life saving procedures where you are either delaying or doing something wrong. Those are like straightaway failures. The other thing where they will not pass you is them knowing that you knew the station from outside. So if you were scripted or you knew the station from outside and tried to give the same findings, even though they're not there. So you're making up stuff in your head and assuming the station is about this instead of actually listening to them. Because they will change the station very subtly and you might not even notice. And if you miss that, they can fail you. Be very careful when it comes to safety netting. I cannot emphasize this enough. Like, if you remember one thing from this webinar today is be a safe doctor, okay? If you're unsafe, you will not pass this exam. I want to ask how we will practice procedure skills station in the long course. So this is an online course and we don't actually do the procedure. I try and explain the procedure as well as I can, and then candidates do the procedure and send me videos. That's how it works. They go to their hospital, and many procedures are fairly simple, by the way. You don't have to have like technical skills because they're also being performed on a dummy. For example, procedure skills like nerve blocks are performed on a dummy and they don't allow you to open the needle even. So they are just more of you telling what to do and then pretending to do it. So no need of practicing technically. Second, is the actual procedure they do make you do is one catheter. Second would be suturing. And then you have chest drain or needle aspiration, things like that. They're also sort of verbal. So with these ones, suturing specifically, that's one where many of you fail, and we go into the details of suturing. You send us a video. And I am trying to like procure a suturing kit and just to show you live as well, or maybe actually make a video live. You might not be able to see that well, but like make a proper video for you to see like how you suture properly for this course, this one. But before that, we were just doing explanations. I would share different videos and candidates would actually go to the hospital and suture and show me how they're doing and I would fix their techniques. Because suturing is one station many of you will fail. We don't suture the same way as we do in the UK. But most of your practical stations, by the way, procedure skills and examination is videos, and then you send me your videos. They're always open. Examination wise as well, the more you practice, the better you get. I will share the videos with you. And this is not for just the course people. The videos are available for free, by the way. Just go to Oxford Clinical Examination. I will just type this here. Just type this in Google. This will come up. This is a free video channel, good videos for all types of procedure and examination skills, free for all of you to watch. So use this. They do have ads on the website, so be careful. There's a lot of pop-ups now, but still a very good website. I hope that answers the question, Larry. What is the difference in Malaysia and London diet? Nothing. There's no difference in marking. Yes, you can find a difference in the passing score because you might not see a lot of UK graduates there. So many of the London diets, you are competing with UK trainees and graduates, okay? So they are already ahead of you when it comes to communication, safety netting, advice, and a lot of other things. But you still have the knowledge, you still pass. I have not appeared in Malaysia diet or Indian diet, so I cannot specifically say, but I can tell you from the candidates who gave the Malaysia diet, they found the actors to be less immersive. So they were just too fake to get that kind of emotion that you would. In London, the actors are amazing. They give you that emotion, like the crying and the bad news. And so you automatically become more empathetic. That has been a feedback. And secondly, obviously, you're competing with UK graduates. So you have to bring your A game to the London diets. But that doesn't mean Malaysia diets is easy or a lot less difficult. It's still difficult. You still have to prepare. It's still confusing as how to structure a station, even if it's a hybrid one, but I believe practicing long. Probably have a look at, you're already enrolled, Alina. Have a look at the videos. You will understand how the structure works. And you will realize once we start practicing as well, if you understand what's going on, for example, you understand you're asking some history questions, right? You would automatically have a baseline. You will automatically be asking some questions and signposting. And when you get to the management plan and they're like, I think you need an MRI, for example, and they say, no, I don't want one. Now you are in conflict territory, right? So you know, whenever there's a conflict, you ask why. So why do you think you don't need an MRI? How can I make this better? Explain why they need an MRI and then bring them back to your point. So that's just presence of mind. And again, I would say this is basically what you do in actual ER. That's how you treat patients, isn't it? So anybody who's not working in the ER and have been away from clinical practice, you will struggle. So move to a clinical practice now. You will struggle in the exam. Because this is, many of those OSCE stuff, you will realize, comes a lot more naturally to you if you're just working in an ER. Is this a YouTube channel? It's opening up Oxford books. No, it's a website. And Aska, you've already got access to this one. I've shared this when you did the long course with me. I will look it up and I will share the link in the open OSCE group, okay? I'll share it again, don't worry. If I go back from like the laptop now, it's just gonna shut this screen share, unfortunately. So I'm gonna share it again, don't worry. Okay. Any more questions? Any concerns when it comes to OSCE? Any confusion? Many of you ask about the seat as well. The best time to get a seat is going to be the end of the year or the start of the year, so December, January. Many candidates don't like to go for the December diets because of Christmas, so you get those. And January ones as well, like December, New Year, it's the holiday season. Many UK graduates avoid it. That's why I think this time they're making the exam come closer, not December. They've made it in November, I guess. So you might be competing for the UK graduates, but many of them is fine. St. Emlyn's blog is a website, not a YouTube video. Just type it in Google and it's gonna come up. And you have to go into the FRChem or MRCEM OSCE. Just type in MRCEM OSCE St. Emlyn's blog and you will see it there. It has all the structures written, so you have access to it. How long it takes to prepare well in general depends on your baseline. This isn't a one size fits all kind of answer. If you have NHS experience, if you're working in a setup where you're already speaking in English, you can just do this exam in 3 months, easy. If you're in a setup where you have a language barrier, you're not speaking in English, and you are in clinical practice, though, it might take you 4 to 5 months with a good baseline. If you're somebody who's working in, for example, Pakistan, in a setup where you're speaking an entirely different language, you don't have UK guidelines, now you are struggling. So you will need to first shift your mindset to using UK guidelines, then using their frameworks, then coming to English, and then having a complete like structured preparation that can probably take you from 6 months to 7, 8 months, depending on how quickly you pick up English. Many people struggle with English more so than the knowledge part itself. You have the knowledge, you are a good doctor. It's just framing what you want to ask clearly in English is a problem, which is where you guys lack. And so you lose marks in communication because you cannot get your message across. In your head, that sentence makes sense. But when you ask it, you're stuck. And this is especially for London diet people, because you get simulators that are British. They speak in a British accent. They speak quickly, like I do sometimes, which I apologize for, by the way. Just sometimes I do go on a rant and I can talk really fast, which is why if you are watching the videos, just slow me down, okay? Go to, instead of using the 1x speed, go to 0.75 or 0.5 even, if you want to make notes, because I can tend to talk faster, and you British graduates will also tend to speak faster, by the way. So keep it to a slower speed. Oh, thank you about that. Do check out the Substack. I do have some blogs on Substack for helping with MRCEM OSCE. And some of the MRCEM OSCE knowledge that you need is also in the SBA blogs. Like, have a look at the leadership skills, and some of these blogs will have some information. So do read up on that. I was planning on updating a few other blogs on it just for OSCE because of some latest changes in recent diets. We've had some triage prioritization that I updated recently. Do read up on it. Prioritization is important. And some leadership skills were updated. Do check that out. I also have a video on ED prioritization because they were starting to give that station very often. So do check the YouTube video out as well, just for your information. And you will notice some of these are AI generated videos. Don't worry, the AI is just talking because I don't have time to like go live and talk. The material given to AI is all handwritten or made by me, so it has the correct information. It's just AI talking. So I had that. Somebody asked me that question as well, like, did you check what it's saying? So yes, I did. All right. Anything else? What time is it? Oh, we still have 4 minutes, guys. We're doing good. Any other concerns? I am in the process of looking at the updated OSCE book. Someone got a, what do you call it? A hard copy of it, but I'm looking to find a PDF version of the latest 25 OSCE book, 125 OSCE book. So let me see. But even then, like, the guidelines are still outdated in these books. So you do have to update it. Oh, another thing, I'm going to give you these NHS website. So this website is good for patient-related knowledge, okay? Don't use jargon. So now, you're not supposed to use jargon, but then how do I explain this disease? And it gets difficult. So NHS website has good patient encounter words that are not jargon. And the second one is patient.info. Now, patient.info has management plans as well. So patient.info will have a doctor page and a patient page. The patient page is what you tell the patient, and the doctor page is what you need to know about that certain condition. So whenever station you get, open patient.info and read on it. It has latest guidelines, updated ones, so you're less likely to go wrong. Okay, I hope that helps. What else? What else can I think of that I haven't given you? Nothing really. Examinations. The thing with examinations is this is an online course, so I cannot make you examine, right? And I thought about, because I never did a course and I never had that experience of like going to a course and doing like examinations live. The thing is, how I prepared is the advice that I can give you. I would do one examination a day before my exam. And I did this for 2 weeks only. So for the straight 2 weeks, I would do one examination on all my patients, all of them. So in an ER, for example, today I want to do respiratory exam, right? I would do the respiratory exam as the guidelines are on every patient of respiratory that I get that day. Cardiovascular on all my patients. Abdominal, properly done on all my patients. And then musculoskeletal as well, the same. I would ask them to put me in minors. So with minors, you get a lot of ankle sprains, shoulder sprains, dislocations, stuff like that. And I would stay in minors for like 2-3 days and do all my musculoskeletal examinations. Then thyroid, again, you build your own preparation course, okay? It's up to you because it's your exam. Nobody's going to take the headache. So you have to decide this for yourself. And so whenever we do the examination week in our long course, I advise candidates to focus this week. Every single day, you're going to do one examination. 7 days, 7 examinations. That's how you want to do it. And get into the habit of doing these examinations this way. Now, I know even in NHS, when we don't have the exam, we kind of take a laid back approach to examinations and we're not that specific or exam oriented. But revision is important. Even if you're not actually doing those things on a patient, have a structure in your mind and be like, okay, ideally I would do this, just so that you have that reflex. In the exam, that's what they're looking for. If you're awkward in the examination station, and you're struggling to like remember which test to do when, which to do they can pick up on it. And I can tell you, even on an online, if I ask you to tell me about a hand examination, like just to tell me, not do, tell me, I can pick up if you've done it or not. So if I can do it, if I can pick up on that in like 2 years of experience, the examiner sitting in the exam have 10, 20 years experience. They can actually look at you and know how experienced you are. So do not try to fool them. Practice, please. Okay, I hope that helps. Anything else? If we don't have any questions, I'm happy to end the session. If you do, ask away, please. You are welcome.
Yes, Dr. Muhammad, thank you for the presentation. Yes, I came late. Maybe some mismatch with my time here in Oman. Yes, before the difference was 4 hours. Now became 3 hours, and I don't know about this, so I came late. Yes, if you can summarize what you said briefly.
We have a recording of the session, so I'm going to share that as well, just in case you missed it. Yeah. Where did you join from? Like, can I have an understanding of where you joined the session?
Oman.
No, not the location. I meant, where was I, like, in the presentation when you joined the session?
No, just I joined just 3 minutes ago.
Oh, okay. Then I think the best option is to go for the recording.
Because
I'm going to share it.
According to maybe before 2 or 3 months UK time was, there is 4 hours difference. Now 3 hours difference. I don't know what happened.
It's okay. I'm just going to summarize.
mm,
We just went over the basics of how to score
okay.
well in an OSCE station. And the major takeaway from the session was good introduction, good closure, and safety netting. I want you to be a safe doctor, regardless of whatever station you have in the exam, even if you know it or you don't know it. I've also shared some important sites to have a look at, and I'm just going to share them again for you. So St. Emlyn's blog, you want to have a look at patient.info, good for information that you want to have to avoid jargon, and then NHS website. And they also, a very common question that you will see in the stations this time around is meningococcal vaccine related stuff, because they've updated it. They've had a measles outbreak and a meningococcal outbreak recently. So do read up on those guidelines, by the way. Okay. But yeah, I'm sorry that the time didn't match and you kind of missed most of it, but do not worry. I'm going to put this recording on YouTube and I will share it in the open group so that you can just listen to it again. But yeah, the gist of the whole session was just this basics of how to start the preparation. After seat confirmation, how much time we have left for exam? So this varies. If you are in the prioritization group, like if you're working in the UK, you are a UK trainee or working in Ireland, you will have been informed of having the seat roughly 55 to between 55 to 45 days. Okay. And that's a good enough time. However, if you are not in the prioritization group and you're in the group 4, you will be offered a seat on an oversubscription criteria. And those seats are usually offered within 30 days to even less than 2 weeks. So be very careful. The last time in December, last year, December, they offered a seat within, I think, 3 weeks. And that those people struggled with like visas, and like in that 3 weeks time, imagine you have to get your visa sorted, packing, a lot of other things. So there's so much going on. So I would recommend like being prepared whenever you apply for the exam. Whenever you're applying, you should be in your head thinking, I'm ready. All I need is practice, I'm ready. So keep that in mind. Secondly, anybody who gets a seat now, and this is specifically for those going from Pakistan, by the way, but general advice for somebody who's traveling to UK for the exam. I have videos up on the OSCE, on the YouTube channel for what to do after getting the OSCE seat. It has advice about airplane tickets, hotel booking, anything near the RChem exam center, how to get from the airport to the center. For anybody who's traveling for the first time, I made those videos so that you have everything in one place, even the visa process, like how to apply for visa, what to put on the application to avoid getting rejected, how much you should have in your bank, blah, 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 all of those things. Everything's in a video. Go and have a look. And the reason I made that was because I found it very distracting when I was giving my OSCE exam. Once I got the seat, I was so consumed by all of these things like packing, visa, hotel booking, flights, that I would barely have time to actually practice. And I was getting stressed. So I wanted to take that thought process away so that you could focus on the training and practicing and preparing for the exam, and you don't have to worry about anything else. So once you get the seat, do check out those videos where every advice is given. The advice is specifically winter related months. So if you're going for the exam in the summer in the UK, it might not apply, but it's for January and December dates because I went in January. I went in December, but January is the same kind of weather. It's winter. So the advice regarding what to pack clothing wise, what to wear to the exam center, all of those kind of little advices are winter related. But if you get a seat in summer and you want me to do like a summer video for it, I'll do that one. But yeah, general advice for all of you who are traveling to UK, I've done a video. I am in the process of finding somebody who's gone to Malaysia to give the exam so that they can make a video for you, so that you have some advice on like Malaysian visa process, hotels, and where they take the exam and stuff. We don't have that yet. I hope that helps. All right. Any other questions? Or are you happy for me to close the session? And for all of you who joined late, we will upload the recording straight away. Just give us about 2 hours and you will see this on our YouTube channel, and I'll share the link in the group, okay? All right. Thank you very much for your time and listening. And I hope this was useful. And if you still need help, the group is always available. Just I'm a message away. And I'll see you all next time. Allah Hafiz.
Okay, thank you.